welcome all on a Saturday afternoon to discuss regarding monkeypox. As you all know, as of 2nd June, about 436 cases have been reported in 18 European countries. In addition, about 289 cases have been reported in 10 other non-European countries. And so overall, we are talking about now almost 700 patients now, right? Among those countries, England is, of course, UK is, of course, a huge, over 200 patients are from UK alone as of 2nd June. And so it is spreading, and 80% of the cases of these monkeypox are in UK is in London. And so very urban setting, it is spreading. And so if we want, I presume it's a matter of time, we will get our first monkeypox case. In countries outside UK, Canada, US, it has predominantly been a travel-associated disease for the time being. And so we will, as a matter of time, we will get patients coming in with a history of travel and having monkeypox, especially since now MyICID reminds them to look out for the lesions. But if we don't want ourselves to become like UK, I think we'll have to have 3 things going for us. Number 1, the patient, as soon as he gets the rash, has to come and seek care in a primary care facility because they may not feel sick. And so it's important they come and seek care. The second one is when they seek care, our primary care doctors have to now what shall I say, say nothing wrong with it, don't worry, it's heat rash or something like that, and discard their symptoms. And number 3, of course, our public health team does a good contact tracing and find out all the close contacts and isolate them. If we can do all these 3 things, then of course, we will not, what happened in UK won't happen to us. So in that vein, so we are having this webinar to target to one important thing, that our primary care doctors are ready to recognize the case, diagnose the case, and then pass it on to public health officials to do the relevant contact tracing. So for that purpose, we have lined up three doctors who are all involved in heavily involved in the design of the current monkeypox guidelines. Dr. Lim Ka Chuan is the ID physician based in Hospital Sedang. Tang Ji Jong is a dermatologist based in Hospital Ipoh, and Rohani Jahis is from Disease Control Division, Ministry of Health. So they have actually, in order to make sure there is no disturbance with regards to internet and all that stuff, they have recorded their videos, and we will play their recorded videos, but they are available in person to answer your questions subsequently. So without further ado, I will invite the first speaker and his recorded video, Dr. Lim Ka Chuan. He'll introduce monkeypox to us. Can we go ahead? Thanks.
Good afternoon. I'm Lim KC, ID physician currently practicing at Hospital Sedang. The topic of my presentation is Introduction to Monkeypox. Monkeypox virus is a DNA virus. It is a zoonotic disease, meaning it is transmitted from animals to humans. It occurs predominantly in Central and West Africa, as shown in the map here. The virus belongs to the genus called Orthopox virus, under which there's a historically more famous sibling called smallpox virus. However, monkeypox is less infectious, as well as it causes less severe disease comparing to smallpox. Just like COVID with different variants, for example, Delta, Omicron, monkeypox also has 2 clades. They are West African clade and Central African clade. The naming of the clade is obviously following the regions where cases are reported. West African clade is less infectious and less severe with lower case fatality ratio, as shown in this table, as compared to Central African clade. Since it's a zoonotic disease, what are the possible animal reservoirs? Monkeypox, as its names imply, could be found in monkeys. But there are other possible animal reservoirs too, namely squirrels and other rodents. Hope you are not as boring now as the monkey in the photo who is your name. How is it transmitted from animals to humans? It occurs via close contact with an infected animal or materials contaminated with the virus. On the other hand, human-to-human transmission is not so common as it requires prolonged exposure. The transmission can still occur via direct contact with persons with monkeypox skin lesions or contact with materials contaminated with the virus, for example, clothing and linens. In addition, the disease can be transmitted via respiratory droplets too, when a person with monkeypox coughs or sneezes. Now, let's look at the timeline of reported monkeypox. It was first discovered in 1958 when outbreak of a pox-like disease occurred in monkeys kept for research. Then, the first human case was reported in 1970 at Democratic Republic of Congo. It was contained in Africa continent until 2003, when there was an outbreak of monkeypox in USA. In fact, this was the first human monkeypox reported outside of Africa. It spreads from imported African rodents to prairie dogs. For dog lovers, don't worry, prairie dogs are not dogs, but a rodent as shown in the photo here. During this outbreak, there are 47 human cases. All were West African clade, fortunately, which is less infectious and less severe, and all recover. Subsequently, there are reported monkeypox virus outside of African continent, like UK, Israel, Singapore, but majority were related to traveling from endemic African countries. This was true until the current outbreak, which occurs in May 2022. The first case of current outbreak was detected in London on 7 May 2022, which is related to travel from Nigeria. This is followed by additional cases across England, causing the first community transmission outbreak in Europe. As AirAsia's slogan says, everyone can fly, this holds true for virus too. With the ease of the traveling and gathering, until 24 May 2022, there are more than 240 cases reported in at least 18 countries. Of the cases with available information, more than 110 cases are males, while one suspected case has been reported in a female. Most cases have been detected through sexual health services, especially among MSM. Again, fortunately, the preliminary data shows it is the milder West African clade. The postulated possible mode of transmission is contact with infectious skin and mucosal lesions during sex. One might ask and rightfully be concerned that there are mutations to the virus that makes it more easily transmissible. Studies are ongoing on this matter, but so far there's no evidence to suggest that's the case. Now, let's look at the clinical features of monkeypox. It can be divided into 4 phases, namely incubation period, febrile stage, rest stage, then recovery. First, the incubation period is between 5 to 21 days. Then, patient will develop prodromal symptoms for 1 to 4 days. For example, fever, swollen lymph nodes, and flu-like symptoms. Subsequently, patient will develop rash for 2 to 4 weeks before going into recovery. If we dissect further into the frequency of symptom signs of monkeypox, we can see that all of them have rash, and about 70% of them have lymphadenopathy. Other symptoms are common too, but has less differentiating values compared to rash and lymph nodes. With regards to rash in monkeypox, I will not go into too much detail as it will be covered by the next speaker, but the important points are they progress uniformly in stages. Progresses from macules to papules, then vesicles and pustules, then to scabs and scars. This is in contrast to chickenpox rash that appears in various stages of development at the same time. As mentioned earlier, the lesion will progress from macupapules to vesicles, pustules, of which some may be umbilicated before clustering and formation of scabs. So, are there any clues to suggest monkeypox or chickenpox, vice versa? There are a few, as shown in the table here. Firstly, limb adenopathy is present in monkeypox, but not chickenpox. Secondly, monkeypox lesions involves the palms and soles, which is rare for chickenpox. Thirdly, with regards to lesion distribution, monkeypox lesion is centrifugal. That is more dense at face and limbs, while it's centripetal for chickenpox. That is more dense at trunk. The fourth point is what I have mentioned earlier about the progression of lesion in stages. However, there are reports that say for current outbreak, atypical features were found. What are they? It is reported that rash often starts in genital and perianal areas, which can be easily confused with sexually transmitted infections. Also, the rash sometimes did not disseminate to other parts of the body, and the prodromal symptoms were mild or not occurring at all. For now, we don't know the reasons for these atypical features. Nevertheless, when I look into this newly published case series of monkeypox cases, I realized this might not be the case. This is a UK reported retrospective study of monkeypox cases from 2018 to 2021, that is before current outbreak in May 2022. There were 7 patients, 4 men and 3 women. 4 were travel-related. 1 was nosocomial, while another 2 were household contacts of a traveler. Of these 7 patients, 5 had perigenital lesions. So this brings to the questions whether it is actually an under-recognized feature or atypical feature during current outbreak. I don't have the answer now. In terms of infectivity period, one is infectious once symptoms begin. This includes prodromal symptoms. Then, he or she is no longer infectious after all the scabs fall off. This process may take several weeks. Along the course of illness, what are the potential complications of monkeypox infection that you need to be aware? These include dehydration due to GI loss, bacterial superinfections, especially over the skin and eyes, conjunctivitis, keratitis, pneumonitis, abscess formation, airway obstructions, and encephalitis. But these complications are uncommon. Nevertheless, it could happen in certain high-risk groups. For example, unvaccinated against smallpox, pregnant women, neonates, infants, very young children, and immunocompromised groups. Besides host factors, the widest factors that can predispose someone to more severe disease is infection with Central African plague, also known as the Congo Basin plague. With regards to case fatality ratio, as you could see in this table, it varies between reports. Generally speaking, the case fatality ratio for West African plague is 1% versus 10% for Central African plague. In fact, there were no recorded deaths during the outbreak in 2003 at USA, which involves West African plague. This might be partly explained by the level of healthcare supports available. So, seems like the mortality is not high. What about other long-term consequences? Patients might suffer from skin scarring or reduced skin pigmentation after the episode. Some might even experience blindness due to corneal ulcers. Now coming to differential diagnosis. If you search fever and rash at Google, tons of causes appear. So it is possible that healthcare workers might be easily confused with other infections like chickenpox, zoster, measles, herpes simplex, syphilis, and other STDs. The next speaker will highlight a few differential diagnoses and how to differentiate it. But the key is still none other than comprehensive history taking, recognizing the typical stages of clinical manifestation I have mentioned earlier, as well as getting the correct social histories, namely traveling to countries where monkeypox has been reported, contact with a person with similar rash or suspected monkeypox, as well as sexual history in this context will be MSM. In addition, one needs to examine the skin thoroughly to look for the typical characteristics of the lesions. Once you suspect clinically the diagnosis of monkeypox, you need to confirm it with lab tests. In this case, PCR test. In Malaysia, IMR or MKAK can run the monkeypox PCR test. The best specimen to be sent for PCR test will be vesicular swab of lesion exudate or crust. On the other hand, blood specimen is often inconclusive due to short duration of viremia. And not to forget to wear appropriate PPE during specimen collection. This table is from our KKM interim guideline on monkeypox management. As you can see here, the choice of specimen depends on whether you are handling suspected case with rash or close contact in the prodromal phase. For suspected case, like I mentioned, swab of the skin lesion exudate or crust is the best. But for close contact case, in prodrome phase still, there's no skin lesion for you to swab. Therefore, one needs to take specimen from tonsillar swab, nasopharyngeal swab, as well as blood for monkeypox PCR. Now, we come to the last section of this presentation, management of monkeypox infection. For now, all suspected, probable or confirmed cases need to be admitted for isolation purpose and notified. The treatment is mainly supportive because the majority are mild and self-limiting. In fact, people vaccinated against smallpox in childhood may experience a milder disease. However, if there were to be high number of cases, this admission criteria will be reviewed. If that's the case, then we will focus on admitting those who are clinically ill or with uncontrolled medical conditions or special population, for example, pregnancy, the very young or very old, just like what we have done for COVID pandemic. Some of the supportive treatment include fever and pain management, skin and eye and mouth care, hydration and nutritional support, respiratory care, and mental health support. In terms of specific treatment, currently there's no proven definitive therapy for monkeypox. However, a few experimental antiviral treatments are available. For example, tecovirimat, which is approved for smallpox, acts by preventing virus from leaving the infected cells. It shows efficacy in animal studies. As safety-wise, it is well tolerated with no serious adverse event reported in phase 1 trial. Another antiviral is cidofovir, which is a prodrug of cidofovir. It also shows its efficacy in animal studies, but is associated with transaminitis. What about post-exposure prophylaxis? Can I give vaccine in this method? Transmission of monkeypox requires prolonged close contact with a symptomatic patient. Brief interaction and those conducted using appropriate PPE are not at high risk, hence generally do not warrant post-exposure prophylaxis. Nevertheless, there are ongoing evaluations of the role of smallpox vaccine for close contacts at increased risk for severe disease. So, how can we prevent outbreak of monkeypox at our healthcare facilities? Thanks to COVID pandemic, we should be very well versed with this now. The basic is still hold true, which is early rapid recognition and triaging, as well as source control. The patient should be rapidly identified at entry points, especially those with rash. They may or may not have epidemiological link. Also, visual alert at entrance to emergency department, outpatient clinic will help to alert patients to inform healthcare worker should they have the symptoms related to monkeypox, so that isolation can be done immediately. Talking about isolation, they should be isolated in negative air pressure room if available, if not single room with attached bathroom. But if still not available, then at least a single room. Standard contact and droplet precautions should be applied. In addition, because of the theoretical risk of airborne transmission, airborne precautions should be applied whenever possible. So what are the PPE for this kind of transmission? They are N95, isolation gown, gloves, and eye protection, just like what you wear to attend a COVID positive patients. While for public, when you travel to countries with reported monkeypox cases, practice good hand hygiene is important as always, and avoid close contact with animals that could harbor the virus, and avoid contact with materials that has been in contact with a sick animal. Once you have returned, you need to self-monitor symptoms for 21 days using the MyICID Health Alert Monkeypox. Lastly, let's look at the risk of monkeypox to different populations for this outbreak, done by the European CDC. For broad population, the risk remains low, but moderate risk for persons with multiple sexual partners, including MSM. With regards to healthcare workers, including lab personnel, the risk is low, provided proper PPE and procedure protocols are adhered to. So in summary, we need to be aware and recognize the case early and notify. Again, remember the characteristic rash as they may not have travel or contact history. The mainstay of treatment is rapid isolation, contact tracing to control the outbreak, as well as symptomatic treatment. In addition, we must understand the mode of transmission in order for us to protect ourselves by adhering to the infection prevention and control measures. Lastly, I think engagement and risk communication with public is another important aspect. Thank you.
Thank you, Dr. Lim. I think he sort of outlined the history behind monkeypox and the current outbreak. I think for me, the take-home points is, of course, while classical monkeypox, as he described, has got the prodrome phase, the lymphadenopathies, and the rashes that has been flashed in media in recent times. It is important to remember that in this particular outbreak, the patients that you are going to that you might see could have very mild prodrome, hardly any prodrome. They feel very well, and the lesions are just limited to just a few spots in the anogenital region. And I think we should, if you want to successfully control this outbreak, we should be able to diagnose these cases and isolate them as soon as possible. There are a lot limited rashes. The second thing I want to highlight is, while it is a fact that many of the patients, the majority of the patients who have got monkeypox currently are men who have sex with men, but I just don't want to focus too much on it for two reasons. Now, one is, of course, it creates stigma, and patients don't come forward when they have a rash because of this. And the second thing, of course, is that's what happened in London, but in a Malaysian setting where we have a closer family unit, it may not be limited to just sexual transmission. We might see a wider group of people getting monkeypox, and so I don't want to label it as a disease among men who have sex with men. With that, we'll move on to the next speaker. I think Lim Kachuan sort of highlighted the importance of rash in monkeypox, and all of us have to learn now how a monkeypox rash looks like, and now what other person than a consultant dermatologist to tell us this. Dr. Tanjijong, go ahead.
Good evening, ladies and gentlemen. I would like to continue with the next presentation on skin manifestation of monkeypox. In this lecture, I'm going to highlight the key features of monkeypox and how to differentiate monkeypox from other infections like chickenpox, hand, foot, and mouth disease, and measles. So first, let's take a look at monkeypox. The clinical manifestation of monkeypox can be divided into 4 phases, namely incubation period, followed by febrile stage, rash stage, and recovery phase. So incubation period, or the interval from infection to onset of symptoms, is usually 6 to 13 days, but can range from 5 to 21 days. And during this stage, the patient is typically asymptomatic. This is then followed by the febrile stage or invasion phase or prodromal period. And during this stage, the patient will present with fever and typically high-grade fever, 38.5 to 40.5 degrees Celsius, and it will be associated with other symptoms, in particular lymphadenopathy, which can be localized or generalized lymphadenopathy. And apart from that, the patient can have headache, chills, sore throat, malaise, or fatigue. And this febrile stage will usually last for 1 to 4 days. So following this, the patient will enter rash stage. Within 1 to 3 days after the onset of fever, the rash of various sizes will appear first on the face and then spread to the arms and leg, and finally, and then hand and feet that include the palms and sole. And finally, it will go to all parts of the body. And in monkeypox, the rash typically concentrated on the face, palms and sole and feet more than the body, or what we call centrifugal distribution. And this is a very important feature of monkeypox that can be used to differentiate from chickenpox. In chickenpox, the rash is typically distributed more on the trunk than the limbs, or what we call centripetal distribution. And the rash in monkeypox will undergo several stages of evolution, from macules, which is flat lesion, to papules, raised lesion, to vesicles, a fluid-filled blisters, and then pustules, pus-filled blisters, and this is then followed by resolution of the rash over time with crust and scabs formation and eventually drop off on healing. The whole evolution will take around 2 to 4 weeks of period, and the skin lesion in monkeypox is often a one-stage disease, or what we call monomorphic condition, which means the rash will go through the same evolution at the same time. And when you examine the patient at any point in time, the rash will look similar. And this, again, another important features that you can use to differentiate from chickenpox. Chickenpox typically is a more polymorphic disorder in which at any point in time when you examine the patient, there will be multiple different morphologies seen. And this can be one important differentiating features between monkeypox and chickenpox. And this diagram shows the evolution of skin lesions seen in monkeypox, from macules to papules to vesicles to pustules, which typically umbilicated shape on an erythematous base. And these pustules eventually dries up and form a crust or scabs, which will heal at the center and form an umbilicated crust. And this crust eventually, on healing, it will fall off. And this is another diagram showing the change of morphology seen in monkeypox. The rash in monkeypox can be associated with pain or pruritus, and it may involve with the lesion in the oral mucous membrane, genitalia, conjunctiva, or even cornea. And these are some of the photos of monkeypox patients. As you can see here, there are multiple deep umbilicated vesicles pustular lesion seen on the body and face. Another close view of the deep papules and pustules on the face. And you can take a note here, the lesion have monomorphic, that means it has similar morphology. Similarly, this is another photo showing generalized papulopustular lesion, mainly distributed on the face, hand, and feet as compared to the trunk. As you can see here, the trunk is relatively sparse and less lesion. Another photo showing the similar distribution, mainly on the face than the body, or what we call centrifugal distribution. And this is another photo showing the papulopustular lesion, mainly on the hand and feet as compared to the body. And the skin lesion in monkeypox eventually heals and scab will fall off during recovery phase. And the infectivity period of monkeypox ranges from 1 day before symptoms onset up to 21 days after the initial symptoms has appeared. And a person is no longer contagious once all the scabs have fallen off and there's intact skin underneath. Monkeypox is usually a self-limiting disease with symptoms lasting for 2 to 4 weeks. However, complication can happen, especially in immunocompromised group or in very young children or elderly group. And this includes secondary skin infections such as abscess, ulcers, bronchopneumonia, sepsis, encephalitis, and infection of cornea eventually leads to loss of vision. And there's a list of differential diagnoses that can mimic monkeypox. And these include chickenpox, hand, foot, and mouth disease, measles, bacterial skin infections, scabies, syphilis, and drug reaction. And I'm going to share with you the important differential diagnosis, especially on chickenpox, hand, foot, and mouth disease, and measles, and how we differentiate this condition from monkeypox. First, let's take a look on chickenpox or varicella zoster. So chickenpox is caused by varicella zoster virus, which is a human herpes virus, and 90% of chickenpox occur in children less than 10 years old, and it is highly contagious, and the patient is infectious for 1 to 2 days before the exanthema or the rash appear, until the last groups of vesicles has crusted. And the transmission is mainly by airborne droplets, but may also spread by direct skin-to-skin contact. And the mean incubation period for chickenpox is 10 to 21 days, quite similar to monkeypox. And the prodrome of chickenpox include fever, chills, malaise, headache, anorexia, severe back pain, sore throat, and dry cough. And it usually lasts for 2 to 3 days before the onset of rash. And the rash of chickenpox typically begin on face and scalp, and then spread to the trunk, and finally comes to the extremities. And the rash in chickenpox is more concentrated on the body than the limbs. And this is what we call centripetal distribution. And this is an important feature to differentiate from monkeypox, as what I have mentioned to you just now. And again, in varicella zoster or chickenpox, the rash will undergo morphological change. And initially, the rash will present with rose-colored macules, and then it evolves and form papules, and then vesicles, pustules, and crusts, something quite similar to monkeypox. However, in chickenpox, the lesion typically appear in groups, and each group will go through the morphological evolution change. And hence, at any point in time when you examine the patient, there will be simultaneous presence of lesion of all stages of development. And this is what we call polymorphous condition, as compared to monomorphous condition in monkeypox. In chickenpox, mucous membrane such as mouth genitalia can be involved as well. And this is the morphological change seen in chickenpox. It begins with rose-colored macules, and then papules, then vesicles. In chickenpox, the vesicles is typically very superficial and surrounded by an irregular area of erythema. And this is sometimes we describe as dewdrops on a rose petal. And this is quite different from monkeypox, which is usually larger and deeper. And from vesicles, it will transform into pustules, and it then evolve into crust. And then the crust will fall off, and it will leave shallow pink depression that gradually disappear. Scarring is very rarely seen in chickenpox unless the lesion was superimposed with secondary bacterial infection. And these are some of the photos of patients with chickenpox on the face and on the trunk. As you can see here, the lesion is mainly distributed on the trunk as compared to the limb, which is relatively sparse and less severe. And close view of the chickenpox, as you can see here, when you examine the lesion closely, there are multiple different morphology of the lesion. As you can see here, there are vesicles, pustules, and there are some drying lesion, and there are some very early macules and papules. And close view of the vesicles seen in chickenpox, or what we describe as dewdrops on a rose petal, which indicate a very superficial vesicles. Another close view of the chickenpox, which is mainly distributed on the trunk. As you can see here, there are polymorphous condition, many different morphology, as you can see in the photo here. Another close view, as you can see here, there are pustules, vesicles, and drying lesion with a scab formation at the center, and early lesion, macule and papules. And this is one of the pathognomonic seen in chickenpox. And this can be used as one important differentiating features to differentiate from monkeypox. And this table summarizes the important differentiating features between monkeypox and chickenpox. And the most important features is probably number one, lymphadenopathy, which is seen in monkeypox but not in chickenpox. And second is palm and sole involvement, which is seen in monkeypox but very rarely seen in chickenpox. And the third is distribution. Monkeypox is mainly distributed on the limbs and the face rather than the body, or what we call centrifugal distribution. And chickenpox will be opposite, centripetal distribution with more concentration on the trunk than the limbs. And then the lesion seen in monkeypox is usually hard and deep-seated, well circumscribed and umbilicated. However, in varicella zoster or chickenpox, the lesion is more superficial and the vesicle is typically described as dewdrops on the rose petal. And in monkeypox, the lesion is monomorphous, whereas in chickenpox, the lesion is polymorphous with multiple morphology when you look at the lesion closely. Now, I would like to move on to the second condition that can present with vesicles that can mimic monkeypox, that is hand, foot, and mouth disease. So hand, foot, and mouth disease is caused by picornavirus, in particular Coxsackie virus A16 and enterovirus 71. However, other serotype of virus has been identified as the cause of hand, foot, and mouth disease. And these include Coxsackie A5, 6, 7, 9, 10, B2, 3, 4, 5, and C1. These serotypes would depend on the region of the outbreak. And the age of onset for hand, foot, and mouth disease is typically less than 10 years old. However, it can also occur in young and middle-aged adults. Hand, foot, and mouth disease is highly contagious. It can spread from one person to another person by oral to oral and fecal to oral routes via air droplets or contact with the infectious material. And 1/3 of patients with hand, foot, and mouth disease remain asymptomatic. And symptomatic patients are mainly children less than 5 years old. And it has incubation period of 3 to 6 days, which is much shorter than monkeypox and chickenpox. And again, it begins with prodromal symptoms such as low-grade fever that lasts for 2 to 3 days. And it can associate with anorexia, malaise, abdominal pain, and cough. And hand, foot, and mouth disease will begin with oral lesion and also skin rash. In terms of oral lesion, it can start with macular lesion that appear typically on the buccal mucosa and also tongue and hard palate. And the mucosal lesion will rapidly progress to vesicles and then erode and become surrounded by an erythematous halo. And at the same time, the patient can present with skin rash, which typically begin with macules and then papules, and then quickly evolve into vesicles on an erythematous base. However, these lesions are usually very tiny, ranges between 2 to 8 millimeters. And the vesicles seen in hand, foot, and mouth disease is typically elongated or elliptical in shape following the skin creases. And it is painful and usually do not rupture. And the site of involvement is again localized, mainly to the hand, sole, buttock, and genitalia. And this is a close view of the oral vesicles or erosion seen in the mucosa area in hand patient with hand, foot, and mouth disease. And another photo showing the vesicles on the hand and feet and in the mouth. As you can see here, the vesicle in hand, foot, and mouth disease is typically elliptical in shape, surrounded by erythematous halo, and it is following the long axis of the skin creases. And hand, foot, and mouth disease can also involve genital area and also buttock region, and sometimes this can be misdiagnosed as scabies. In hand, foot, and mouth disease, it should be noted that the exanthem is not always present at all sites of predilection, and this is sometimes known as incomplete form of hand, foot, and mouth disease. And the clearance of hand, foot, and mouth disease will be expected after 5 to 10 days. And fever usually subsides within 48 hours, and the cutaneous and mucosal lesion will disappear in no more than 7 to 10 days. And this table summarizes the differentiating features between monkeypox and hand, foot, and mouth disease. First is lymphadenopathy, which is seen in monkeypox but not in hand, foot, and mouth disease. Secondly, oral ulcer, which is commonly seen in hand, foot, and mouth disease but not in monkeypox. And third is lesion appearance. In monkeypox, the blister is hard and deep, umbilicated, well circumscribed, but in hand, foot, and mouth disease is usually small vesicles ranging from 2 to 8 millimeter on the erythematous space. And in monkeypox, the lesion is generalized with centrifugal distribution, mainly on the limbs and the trunk. However, in hand, foot, and mouth disease, the lesion is localized to the hand, feet, buttocks, and genitalia. Now, I would like to move on to the fourth condition, which can also mimic monkeypox, that is measles, or also known as rubella. So measles is a highly infectious childhood viral infection. It is caused by measles virus, which is a form of paramyxoviridae virus. And transmission is mainly by respiratory droplets via sneezing and coughing. An infected person can remain contagious several days before onset of rash, up to 5 days after the lesion has appeared. In measles, the incubation period is around 10 to 15 days, and this is then followed by prodromal period, and typically the patient will present with fever lasting for 2 to 4 days, followed by the 4C, which include cough, coryza, conjunctivitis, and also Koplik spots. So the rash seen in measles is typically erythematous macules and papules that appear on day 4 of febrile illness. And the lesion is non-vesicular. And this can be a very important clue to differentiate measles from other vesicular conditions like monkeypox, chickenpox, and hand, foot, and mouth disease. And the rash seen in measles typically appear on the forehead at the hairline and also behind the ears, and then spread inferiorly to the face, trunk, extremities, palm, and sole, and reach the feet by day 3 of the lesion. And then the lesion will fade in order with residual yellow tan stain of faint desquamation. That means when it resolves, it will leave some pigmentation on the skin. And the measles rash will resolve within 4 to 6 days. And apart from that, as I mentioned, Koplik spot is a pathognomonic lesion seen during prodromal period. And this is a lesion seen around 2 days before the rash appeared. And it is characterized as cluster white lesion on the buccal mucosa. And it is quite pathognomonic for measles. And sometimes Koplik spots is described as grain of salt on wet background. And this Koplik spot will fade off as the rash appears. And this is another close view of Koplik spots seen in measles patient. And this is a rash seen in measles. As you can see here, this is non-vesicular lesion. And this table summarizes the main differentiating features between monkeypox, chickenpox, and measles. And the most important features is the rash appearance. Monkeypox and chickenpox are both vesicular lesion, and measles is a non-vesicular lesion. And the rash in measles is rapidly evolving over 5 to 7 days, whereas in monkeypox, it is a slow progressing period, taking up to 3 to 4 weeks. And the other important thing is complete spot seen in measles during prodromal symptoms, whereas lymphadenopathy is a key important features that can be seen in monkeypox. And mortality rate is up to 11% in monkeypox, but very rare with chickenpox and measles. With that, I would like to thank you for your kind attention.
Thank you, Dr. Tai. I think that's a detailed explanation on the rash, because as we have mentioned earlier, we all have to get this knowledge of how to recognize the different rashes from recognize the monkeypox rash, and also recognize the rashes of common stuffs that we already have in Malaysia, which will be chickenpox, hand, foot, and mouth disease, and measles. And yes, in a very useful manner, compared those two, these different viruses. And I think as a reminder, it's available as a YouTube for you to see later, and again memorize it again. So the last speaker for the session is Dr. Rohani Jahis. He's a senior public health physician based in Center for Disease Control, who's got wealth of experience in vaccine preventable diseases and zoonosis, and now she's going to talk about the case definitions, the notifications, and the contact tracing that will be done for monkeypox. Dr. Rohani.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Today I will share with you what the MOH Malaysia has done and plan to do as part of the public health management of monkeypox in Malaysia. Just an overview of the global situation of monkeypox outbreaks. Officially, WHO reported, dated on 28 May 2022, there were 22 affected countries in 4 WHO regions, and there were 255 confirmed cases with 54 to 64 suspected cases. And these countries are non-endemic monkeypox countries, and most cases have no history of traveling to endemic countries. And quoting one unofficial data from news on 29 May 2022, actually there were 32 affected countries with 406 confirmed cases and 88 suspected cases globally. So as mentioned by previous speakers, the monkeypox is a zoonosis disease transmitted to human through contact with infected animals, as reported in Israel in 2018, or handling or eating bushmeat, as history given by the case in Singapore in 2019. And human-to-human transmission occurs when there is a close contact with a case, either face-to-face through droplets or skin-to-skin contacts. Based on the current situation of monkeypox infection globally, there is a risk of monkeypox importation into Malaysia. And if case does not come forward, then there is a risk of spread in the community. This is because Malaysia has opened our international borders and travelers can come without any restriction, as during pre-pandemic period, now they can enter to Malaysia freely. This is also in line with WHO recommendation, which no restriction imposed on travel and trade related to monkeypox incidents. There is a risk that an infected person in the incubation period travel to Malaysia. He does not have any symptoms that can be detected through thermal scanner. Basically, thermal scanner detect fever in the airport, and no maculopapular rash on the face or hands for identification by our frontliners at the point of entry. At the moment, Immigration Department has agreed to assist us in identifying suspected cases when they see travelers with such rash and refer the cases to the health team at the point of entry. Infected people also might come to health facility, might not come to health facilities, thinking that monkeypox is a mild disease and self-limiting. International reports highlighted monkeypox cases among people with high-risk behavior, and this group of people might not come forward because scared to be stigmatized. So this is also put a risk to importation of cases or spread of monkeypox cases in Malaysia. Another important risk is importation of wild animals from Africa. We had a discussion with the Wildlife Department, or in short Perhelitan, the Department of Veterinary Services Malaysia, DVS, and also Malaysian Quarantine and Inspection Services, MAKIS, that at the moment in 2022, there is no importation of animals from Africa. We continue to be vigilant and continue surveillance for importation of wild animals from Africa. Okay, so to respond to risk of monkeypox importation and spread in Malaysia, we use the principle outlined in the Disease Outbreak Response Matrix, or DOM, that we used during the COVID-19 pandemic response. Let us focus to number 1, the alert phase, where the disease is mainly overseas, but the risk is coming to Malaysia is there. Our role is to detect and minimize importation of disease. So far, we're doing good, but cannot be complacent with this procedure. We continue our response, especially related to international travelers, and strengthen our preparedness in terms of laboratory capacity and case as well as contact management. So for number 2, the early containment phase, when the disease has arrived in Malaysia, however, it's sporadic with no community spread or limited spread, which should require primary response, then we will do the containment activities, meaning to prevent the disease from spreading in the community. Based on the DOM and activities planned and carried out, MOH has came up with the plan tindakan bagi menghadapi risiko kemasukan jangkitan monkeypox ke Malaysia, with an objective to enhance surveillance of monkeypox and to implement the prevention and control activities in order to curb monkeypox spread. And under this plan of action, there are 5 strategies, which are early case detection, strengthening of the lab capacity and capability, case management, management of cluster or outbreak, and raise awareness among community as well as healthcare workers. And all these activities are carried out in collaboration with other agencies based on laws and regulation, which in this management of monkeypox is related to Prevention and Control of Infectious Disease Act 1988 or Act 342, resources including funds and use of digital technology in handling monkeypox threat. In short, these are the main activities conducted by all levels of MOH administration, be it at state and district level. First, raise awareness among the healthcare workers and community to avoid stigmatization, especially to certain high-risk groups, and stress that all are at risk of infection as long as they are in proximity with infected monkeypox case. Second, early detection of cases at point of entry and also in the community in order to diagnose case for prompt action, lab capacity and capability are further enhanced. Third, contain the disease through isolation of cases and quarantine of the contacts in order to stop transmission. And fourth, protect healthcare workers through providing adequate and appropriate PPEs and definitely to increase awareness among them. There are some of the activities under risk communication as to raise public awareness on monkeypox. All these activities are done through collaboration with other agencies, especially MCMC and Information Department. We go online on traditional platform and also social media. Briefing, training, and providing guidelines and FAQ to healthcare workers is part of providing knowledge to healthcare workers, and definitely This webinar is one of a good platform to spread information. Congratulations to the organization committee, the Malaysian Society of Infection Control of Infectious Disease, MyICTC. So, one of the most important activities in public health response to monkeypox case is early case detection. We have collaborated with Airline Operators Committee or AOC and airport management through the International Point of Entry Health Office to announce before departure those flights coming from affected countries. Highlighted that passengers with monkeypox symptoms and signs to do self-referral, seek medical attention before boarding, so to prevent them from coming to Malaysia. Our health officer at the International Point of Entry have briefed the immigration officers to assist MOH in identifying suspected monkeypox cases, as the cases are easily identified through visualization of macular-papular rash on their face and hands. So if they see such cases, they will immediately refer to the health team in the point of entry. MOH also collaborated with other agencies such as Ministry of Home Affairs, Ministry of Foreign Affairs, and Ministry of Higher Education as to increase awareness among travelers from those affected countries. Role of Department of DVS, Wildlife, and Marquis were also discussed to heighten surveillance among imported animals, because they have house animals in the point of entry to do surveillance on imported animals. And all inbound travelers are required to fill up the pre-departure form, which is part of requirement during the COVID pandemic. And one of the questions is place of departure. If they come from monkeypox affected areas, they will receive a pop-up message on monkeypox health alert. So this is the alert, which pop up daily for 21 days, reminding travelers to observe for any symptoms and signs of monkeypox and to come forward for treatment if they have such symptoms. This is available in the MySejahtera application. In the plan of action also, there are lists of roles and responsibilities of other stakeholders in prevention and control of monkeypox in Malaysia. Basically, there are MKN, MOTEC, Ministry of Tourism, Ministry of Transport, Home Affairs, Higher Education, and also KPM, KDN, and also GYM. Okay? So the list of roles and responsibilities are as in table shown. So this is another roles and responsibility as mentioned. Okay. So case definition is very important in early detection of cases. We adopted the case definition provided by WHO on 21st May 2022. The cases are divided into three, which is the suspected, probable, and confirmed cases as detailed in this slide. At the moment, National Public Health Lab, NPHL, and Institute for Medical Research, IMR, have the capacity and capability to do tests on monkeypox using real-time PCR. The capability to do tests is expanded to 4 regional public health labs. Basically, they are in Ipoh, Johor Bahru, Kota Bahru, and Kota Kinabalu. And they also plan to expand the capability in Hospital Langkawi and also Hospital Umum Sarawak to cater regional services. University hospitals have the capability to do the test and will be activated when necessary. At the moment, the government, the Ministry of Health lab capacities these are the lab government MOH lab that have the capacity to do the test. Okay, so actually monkeypox is an emerging disease and it is a threat to our country, even though it spreads quite slow and self-limiting. So to ensure that we act upon cases promptly, notification within 24 hours is necessary. To ensure that field investigation to identify the risk of infection and the risk of spreading, especially to close contact, is immediately carried out. Monkeypox should be notified as any other life-threatening microbial infection as per first schedule of notification list in Act 342. You can see on the slide, it's number 27, 24. Okay. The notification should be done within 24 hours of any suspected case through phone call, notification form, or e-notification system. So just tick at the notification form as others and put the monkeypox. Okay. As mentioned just now, the aim of containment after identifying case is to stop transmission of the disease. So it includes isolation of cases and quarantine of contacts. So order for mandatory isolation of cases is under the provision of Section 14, Act 342, which stated that any infected person or believed to be infected to be removed to a quarantine station for treatment. In this statement, quarantine station is referring to all gazetted hospitals in Malaysia, and all government hospitals have been gazetted during COVID-19 pandemic as quarantine station. Okay, this is different from COVID-19 as you know that COVID cases can be isolated at home. This provision is related to Section 11 of the Act, whereby Malaysia is declared as a local infectious area for COVID. And following that declaration, there is a specific provision in the regulation permitted that isolation of COVID cases can be done at home or at other premises. So for monkeypox, the isolation must be done at the quarantine station, gazetted quarantine station. Okay. Meanwhile, for contacts, they are quarantined for observation or surveillance at any such place, including home and other types of accommodation for certain period of time until he is not a danger to the community. Meaning is they are no longer infectious. And this is a provision under the Section 50 of the same Act. Okay. So once we have identified a case, have isolated them, so it's very important that identification of close contact. And close contacts are defined as a person who has had exposure with a probable or confirmed case of monkeypox in any time from the beginning of the first symptoms until all scabs have fallen off. Basically, there are 3 modes of transmission. 1, face-to-face exposure, including healthcare workers without appropriate PPE. 2nd, direct physical contact with patient, meaning skin-to-skin contacts. And lastly, contact with contaminated items such as clothing, beddings, and other contaminated materials. Contacts includes households, contact in workplace, school, nursery, sexual contacts, healthcare, providers, house of worship, transportation, etc., etc. Okay. So all contacts must be monitored daily for any signs and symptoms of monkeypox for a total of 21 days from the last exposure to a case. Once the contact develops signs of symptoms other than rash, if we look back at the case definition, if they have any sign or symptoms other than rash, he should be isolated and closely monitored for sign of rash for the next 7 days. If no rash develops, the contact can return to temperature monitoring for the remainder of the 21 days. If the contact develops a rash, actually he fulfills the case definition for suspected monkeypox case and need to be isolated, and specimen should be collected for lab tests. Okay. Meanwhile, asymptomatic contact should not donate blood, cell, tissues, organ, breast milk, or semen while they are under symptom surveillance. Under the International Health Regulation, IHR 2005, all probable and confirmed monkeypox cases should be reported immediately to WHO through National IHR Focal Point. At the moment, we have received three suspected monkeypox cases. However, all three were tested negative for monkeypox. Once we have a confirmed case, it is considered an outbreak because monkeypox is non-endemic in Malaysia. So we hope that there won't be any monkeypox case in our country. Very hard all. Okay. And one of the important things is protection of our healthcare workers. Healthcare workers should wear appropriate PPEs and comply to universal precaution as to reduce the risk of getting infections. Wear medical masks and gloves when handling contaminated items such as clothes and beddings. Regular hands cleaning using soap and water or alcohol-based hand rub is fundamental in preventing infectious diseases, not restricting to monkeypox only. Clean and disinfect any contaminated surfaces and dispose properly the contaminated waste. And vaccination can be considered if it is available in the country. Okay, just some highlights on the role of vaccination. At present, there is no specific monkeypox vaccines available. Vaccination against smallpox does give cross protections against the monkeypox, because actually monkeypox virus is closely related to smallpox virus. Data from Africa suggests that smallpox vaccine is at least 85% effective in preventing monkeypox. Yeah. In Malaysia, immunity from smallpox vaccination limited to older persons born in 1980 and below. But protection may have waned over time since the vaccination. However, there is a role of memory cell in smallpox vaccination. So if let's say we are infected with monkeypox, there is a role of memory cell to induce antibody production. Yeah? So you can check your birth cert for evidence of smallpox vaccination. Okay, as shown in these two photos, the one above is born 1979. And the one below born in 1980. Yeah? If you have this smallpox vaccination endorsement, it means that your parents are not anti-vaxxer at that time, or because of the high penalty imposed by the government at that time, which was 1,000 ringgit, or you are younger than me, meaning you born after the 1980. Okay. These are the difference between two available smallpox vaccines at the moment. We have two, the ACAM 2000, which is live attenuated, replication competent, and the latest version is modified Vaccinia Ankara, produced by Bavarian Nordic, which is live attenuated but non-replicating vaccine. So the replication is itself will indicate whether it is it cause side effect or not. Okay, so you can see that ACAM can cause clinical infection and can be transmitted to others because it can replicate. Meanwhile, for MVA, BN does not transmit to others, and the MVA only can be given to those aged more than 18 years and above. Meanwhile, for ACAM 2000, can be given at all ages. And it's given by percutaneous through multiple puncture, 15 jabs with stainless steel bifurcated needle deep into the vaccine. If those can remember, those who have received this vaccine. And meanwhile, for the MVA, it's 2 doses given subcutaneously 28 days apart between the 2 doses. So these are the adverse event related to the Vaccinia vaccines given. Definitely, ACOM 2000 have higher AEFI risk as compared to the MVA Ankara. Okay. At present, WHO does not recommend mass vaccination against monkeypox because the virus spread slower than any other viruses such as the coronavirus. So the main aim in prevention and control of the disease is early detection of case and prompt treatment, including isolation as well as quarantine of contacts, in order to contain the spread of the disease and break the chain of transmission. So, however, MOH plan, if the vaccine is available, we will give the vaccine as a targeted vaccination program for healthcare workers at risk, such as those handling monkeypox cases, including lab personnel and also close contacts, given in a ring vaccination methods. So, in conclusion, actually, there is a risk of monkeypox importation and spread in Malaysia. So it is important that heightened surveillance and vigilance of all health factors to detect case early, so prompt action can be taken to prevent its spreads. And the spread of virus can be contained if cases are detected and isolated early and the contact are quarantined effectively. Thank you for your attention.
Thank you, Dr. Rohani. I think highlighting the role of Ministry of Health and the plans from Ministry of Health, and also regarding the case definitions and notification timelines. And I think if you just, I just tried it just now. If you just Google case definition monkeypox, Ministry of Health, the case definition is available for you to keep on hand when you see a case, because even a suspect case has to be notified. So what I'm going to do is I will group the questions and then ask the panelists who are available now live now. Limkochon, they're asking us regarding where the lymphadenopathy was found. Have you seen any case reports where the lymphadenopathy is found?
With regards to lymphadenopathy, for the current outbreak, the information is still scarce. But if I look to the Nigeria data, the Cameroon data, or the Republic of Congo data, there's no special predilection for any special site. So any site could be, but it can be cervical, it can be submandibular or axillary or inguinal. So those are no special predilection for any sites of the demand. Yeah.
Dr. Tang, you want to add anything?
Yeah, I agree with Dr. Lim. From what I read, it can be either generalized or localized. There's no specific pattern of lymphadenopathy or any predilection site. Yeah.
Dr. Rani, I think some questions on vaccine, isn't it? So people want to know whether are we getting the smallpox vaccine? What are the efforts being done to get the smallpox vaccine? Can you hear me?
Yeah. Okay, thank you, Dr. Actually, smallpox is already eradicated in 1980s and it's already declared. No, it's only available in 2 places, in Russia and also in CDC Atlanta. So actually, no countries in the world at the moment giving smallpox vaccination to their population because it's already eradicated. But some countries just keep the vaccine for emergency because smallpox can be used for bioterrorism. So they keep it just for stockpile for preparedness against bioterrorism. So along with this declaration of eradication, we are not going to introduce smallpox vaccination to our population.
Okay. So we are there is no we are not planning, there is no plans to get smallpox vaccine currently, isn't it? Because to give it to close contacts, anything of that sort, isn't it, currently?
We have a talk with the manufacturer, but then the process is ongoing.
Okay.
Once it's available, we plan accordingly, as I said just now.
Okay. Okay. So there's other questions on Limkachon. Maybe you could answer what kits you have to use to collect samples. Do you know what are the things that you're supposed to do? Sorry, you're muted.
Sorry for that. Okay, so for patient in the rest stage, so the best specimen will be the specimen materials from the lesion. So you can either send the roof as a tissue in the sterile container, or you can do a swab of the lesion, vascular lesion exudate, putting it in the container, the tube, without a wider transport medium. Then with a triple layer packaging, just like will be done for COVID, and sent to the lab. Yeah. That's the samples for the patient presented with rash.
So sterile bottle, no viral transport media, isn't it?
Correct. Correct.
Okay, got it. Okay. Then the question on infected. I think we have mentioned it before. Can we discuss again how long the patient is supposed to be infective?
Okay. The patient is supposed to be infective until all the scabs have fallen off. So this generally take at least 2 to 4 weeks time. Yeah. Until a new skin has formed. Yeah.
So unlike COVID, we are not giving them a date, isn't it? 7 days, 10 days.
No, not time-based.
So it has to be patient specific, isn't it? We have to wait.
Correct. Just like chickenpox.
Yep. Okay. So it's patient specific. There, we can't give them a date. Okay. There's a question: is monkeypox considered a public health emergency? PHEIC, Dr. Rohani?
At the moment, WHO has not announced it as fake yet.
Okay. Okay. There's a question on biopsy, Dr. Tan. Is biopsy of skin lesion indicated for the diagnosis of monkeypox?
Yeah. Datuk, thank you for the question. So basically, skin biopsy is not indicated as for now. As what Dr. Ling mentioned, the main thing is to get the tissue from the roof or from the fluid within the vesicles or pustules and send for the PCR test. So we do not need a skin biopsy for the diagnosis.
I think there's a question, Dr. Ronnie, you can correct me if I'm wrong. It's asked, may I know what were the presentation of the 3 suspected cases based on travel or rash? My understanding is they were not based on travel, but I think they didn't listen to Dr. Tan's lecture. And so they didn't know how to differentiate the rashes from monkeypox and chickenpox and hand, foot and mouth disease. And I think they were all some other vesicular disease, isn't it?
One is positive for Coxsackie A6 and the other 2 varicella zoster.
So that's why I think Dr. Tang's lecture is very important, and so he has given us the table to differentiate the 3 diseases. I think so far the notifications are because we didn't learn how to differentiate vesicular rashes, and we just lumped all vesicular rashes as monkeypox. And I think it's very important for us to now get the nuances of the different monkeypox, different vesicular conditions in the country, right? What else? I don't understand, how can skin lesions of monkeypox be monomorphic while they spread centrifugally? Dr. Tang, can you explain this?
So basically, the rash will have occurred together, and then it will evolve together. So this is actually a one-stage disease. So when it evolves, it will evolve from macule to papule to vesicles to pustules, and then dries up and form a scabs. So at any point in time when you examine all the lesion, it will look the same. On the other hand, the chickenpox will come in different crops. So first crops, when it happen, it will go through the evolution, and the second crops will come later. So, and then followed by third and fourth crops. So each crops will go through different evolution. Therefore, when you examine the patient, there will be different stages of disease. Some may at the early stage, some might at the late stage in which the scabs have already formed. So that is the main differentiating features between the monkeypox and the chickenpox.
I think that's quite an important question. If we suspect monkeypox at GP level and want to refer, do we need to call an ambulance? A patient go by themselves? I think to answer this question, I think obviously this is the first case, and so my suggestion will be is you contact your PKD if you get the number, or discuss with your ID physician nearby or dermatologist nearby. So discuss the case, so that because it is not a huge outbreak yet, we are going to give personalized care, and we will guide you through the process. So it is best that you have a number with you to contact us, and then we can guide you through. Lim Kachuan and Rohani, any other different advice you will give?
No, same.
Yeah. Okay.
Agree with you, Dato'.
Yeah, just contact us and we do that. Another question, should close contact be quarantined? Yes, they will all be quarantined currently, because as you know, when we start the disease, we will try to keep it under control. I think there was one question that was asked: why are we all making such a big fuss? If monkeypox is morbidly not serious and not so contagious, and low incidence in Malaysia so far, what factors are causing public fear towards this disease? I'll start first, and Ronnie can add on to this. I don't think there's a public fear of this disease currently. We want to have everybody have more awareness, but there is this concern in Europe, and WHO has mentioned that they're concerned if we let monkeypox continue to spread, we don't stop this transmission, it might become endemic. And that is a concern. Like, we don't want to add one more disease to add to our list of differential diagnosis. I think that is a concern. Dr. Rani, what do you think?
Yes, that's sure. Actually, that's our concern as well, because if let's say we do not curb, because at the moment we are talking about special group, but then if let's say we didn't do anything, it will spread to the community, to the rest of the population. So it's going to be endemic. We don't want that to occur in our country, definitely. Yeah.
So there it is a possibility it'll become endemic, and so because like COVID has now become endemic, so we don't want monkeypox, and so it is important that we I agree with you. We shouldn't panic. I don't think it is going to fill up our hospitals. I don't think patients are going to die left, right, and center with monkeypox. But we want to terminate this outbreak and let it go back to Africa and go back to the animals and leave us alone. And so for that, we want to make a fuss. Please look out for cases, identify them, and do the relevant tests and call us for help. So the question about transmission, Dr. Kachwan. So this is about, is it airborne or droplet? Should we use N95 mask or surgical mask is enough? What do you think?
As of now, CDC mentioned that there's a theoretical risk of airborne, but then the transmission, actually the highest risk of transmission when there is an unprotected skin to skin or skin to mucous membrane or skin or to contaminated environment. That's the highest risk of transmission. But because of the theoretical risk of airborne, CDC recommended that if you do have a negative air pressure room, then you do follow the airborne precaution procedures. But if you don't have, the least that we could do is a droplet precaution, especially if there's a possibility of aerosol generalization, as there's a possibility of the virus being in the saliva and respiratory droplets as well.
Yep, I agree. Sorry, go ahead. Finish it.
Yeah, I saw another question about how long, whether to consider whether it's really considered prolonged or exposure or not. like I said, that what I mentioned earlier is really high risk. But if it's just a usual face-to-face contact, even both parties without mask on, CDC said that for you to define as intermediate risk, you need within 6 feet of each other for more than 3 hours contact. This is without whatever high-risk contact that I mentioned earlier, and without any aerosol generalization.
Yeah, I think somebody took the word prolonged contact from in your lecture, and I want to know what is prolonged contact, isn't it? So what I think Lim Kajang is trying to explain was, there is no evidence to say that this monkeypox variant is more transmittable. But on the other hand, we are seeing so many cases. So the hypothesis is this has been prolonged close contact in this community, and hence there is so many cases. That's the hypothesis that has come up, right? So because since it's just a transient contact, shouldn't cause the spread. Dr. Tang, I think because Lim mentioned that it causes genital ulcers. Do you think the genital ulcers will look any different from the skin lesions? What are your tips on what genital ulcers to look out for in monkeypox patients?
Yeah. Okay. So of course, if let's say monkeypox patient present with very atypical presentation, as what Dr. Lee mentioned, that can confine to the genital area, then sexually transmitted infection will be a very important differential diagnosis that we have to entertain. They include common things like syphilis and even genital herpes. So of course, we still can use a few important clues to differentiate monkeypox from the rest. So based on what I have mentioned in the lecture, so monkeypox will have a morphological change. It will evolve from one stage of the disease to another stage. So as compared to a syphilitic ulcer, so it will begin with a very shallow, painless ulcer. And of course, if the patient, in some cases, the syphilitic ulcer actually can heal by itself without even any treatment. So on the other hand, genital herpes would be slightly different. It comes in groups of vesicles, which is extremely painful, and then it will rupture and form multiple punch-out erosion. So there won't be any morphological change as what we normally see in the monkeypox. And therefore, we can use that history of morphological progression to help to differentiate monkeypox from the rest of the sexually transmitted infection. Of course, the confirmation were based on our investigation, right?
Yep. Thanks. I think there's a question about quarantine. How long should somebody be quarantined? How many MCs you have to give? I think our current plan is, we are watching what UK is doing with their patients, and so we are learning from them. And so our current plan, of course, is when we suspect somebody has monkeypox, we will bring them in. We will try to bring them in, not to keep them in the hospital for a long time. So we will bring them in. We will take the relevant specimens, and then we will discuss with them regarding contact tracing and all that stuff. And we are planning to send them home earlier. So don't let patients think that once somebody suspect monkeypox, we're going to keep them for 20-30 days, and so patients are reluctant to get admitted. So we will see them, we will sort out the issues that we have, and then we will send them home in a short time. And so I would recommend that you don't give MC and discharge them, and then pass them to us for us to take discussions with the patients. Okay. So I think this question is coming up again. I probably should repeat, Dr. Tang. From the picture shown of monkeypox, the lesion seems to be larger compared to other vesical diseases. So what is the expected diameter of the monkeypox lesions?
Okay, I'm afraid I don't have the actual figure to tell you how big is the monkeypox lesion as compared to the chickenpox lesion. Based on what I understand, in general, the monkeypox lesion is larger and deeper as compared to the chickenpox or even other vesicular infective cases like hand, foot, and mouth disease. I'm really sorry, I don't have the actual size of the lesion to indicate that whether it's monkeypox or chickenpox.
I think Lim Kok Chang, can you answer this? Since most reported cases of monkeypox now happen in men who have sex with men, does it mean that it's very unlikely to happen in children unless there is positive cases in the family?
Yes, majority of the current outbreak occurs in the MSF community, but it's not exclusive. There are reported family clusters as well. So like I say, a family, now they tend to stay together, they will automatically become close contact. So family contact still could be positive. So not exclusive for everything.
Yeah, I agree. I mean, because our family structures are quite different compared to probably UK and all that. And so I think if the cases were to be reported, I would expect, us to have, it is not unlikely for us to have a family cluster. So family cluster can happen in Malaysia, right? Okay. So I think there's a question about smallpox vaccination. Again, Dr. Rohani, do you think you can answer this? Like I think one of the doctors are probably more earlier than 1980. She asked whether since she said a smallpox vaccine, will she be protected from monkeypox?
As stated by the WHO through the study in Africa, actually it gives protection by 85% efficacy. So if let's say you are, okay, let's say me because I already also vaccinated with smallpox. If let's say I got infected by monkeypox, my memory cell will immediately activated to produce antibody to act upon monkeypox virus because the similarity of the two viruses. So give us some protection.
I think there's a question about case definition being vague, as there are many differential diagnoses to be considered. I fully agree with you, and then I think our plan is to refine the case definition further as we get more information to make it less vague. But I think as you all agree, the lecture from Dr. Tang will help you to differentiate other vesicular lesions that will make us think of that will make us rule out hand, foot, and mouth disease, measles, herpes zoster. We should be able to rule out, and then chickenpox. We should be able to make a positive diagnosis of these diseases so that these don't get notified as monkeypox. And so the key term is having a prodrome before the onset of rash. And then number 2 is having lymphadenopathies. And number 3 is the rash description looks more like a monkeypox rather than hand, foot, and mouth disease or measles. I think these are 3 rules I would apply when I see a patient. I agree with you. The written case differentiation is quite vague, and we will, just like COVID, in the days to come, we will make it better and better and better. Is there any to the panel? Is there any other question that I'm missing that you guys can take up and answer? But before that, I will ask. I'm not sure whether we have the answer for this question. Lim Casey and Tang, can you try and see how will lesions involving the eye or corneal ulcer, how will they look like? Do you guys know?
Okay. It basically can cause conjunctivitis and keratitis. You get a swollen, painful red eye. Then, if you don't treat it properly, it may progress to corneal scarring, ulcers and scarring, then leading to blindness.
Okay. Just I think quite an important question. What local treatment that you would recommend if somebody has monkeypox?
Okay. Yeah, thank you for the question. So basically, the treatment of our the skincare treatment for monkeypox is mainly to prevent a secondary bacterial infection and also to promote lesion healing and also to minimize the insensible fluid loss. Important steps that you have to consider include inform the patient to avoid scratching and picking the skin lesion to prevent secondary bacterial infection, and then bathe or wash with very gentle soap twice a day, and then can use topical antiseptic solution to wash the wound, open wound, and avoid using any topical steroid onto the skin lesion. And of course, you have to observe closely for any alarming sign to indicate that the patient might have ongoing sepsis or infection that include fever, or when the lesion become tender, swollen, red, edematous with a lot of exudates and become very warm, then you might need to initiate antibiotics as early as possible to control the secondary bacterial infection. And of course, in some cases, if let's say there's any abscess formation or very infected ulceration, surgical intervention might be considered.
Thanks. So, Dr. Rani, there's a question about those back from Hajj. Should they have a longer quarantine since they have higher risk of transmitting disease? Is there anything that is being done for Hajj pilgrims?
If you look at the epidemiology of the case and the risk of transmission, I think we do not have to quarantine them as per COVID cases. So basically, if you look at the data, the number of cases in Arab Saudi, I think is only 3 or 2. So we don't have to worry. We just focus on those high number of cases reported in the Europe, because at the moment, IHR focal point in other countries has been working well. Like when you read newspaper last week, Thailand received a notification from Australia whereby a case from Europe travel there was found to be positive for monkeypox, and they notified to Thailand to look after the contacts, and they managed to quarantine the contacts in Thailand. So I guess the system working well, and we do not have to quarantine those coming back from Hajj because of monkeypox.
So anybody has answer to this question? Is getting monkeypox once in a lifetime like chickenpox? Anybody knows?
I actually come across a case report. A healthcare worker gotten the second monkeypox 10 months later, but that is a single case report. So I don't think in terms of immune response post-vaccination or post-monkeypox infection, we don't know for sure now. Yeah.
Okay. I think there's a question being asked, do we need a ID physician to start antibiotic from monkeypox? No, you don't need an ID physician's opinion. But I think the initial cases will be admitted to hospitals because we will be very careful, because we also want to learn about the disease. So they will end up being hospitalized initially if they are severe enough to require antibiotics. I think that's what is going to happen, right? Yeah, I think there's a question about, are there any possibility of organ inflammation in case of monkeypox? So far, reported rates. I think I'll just answer for you guys. So I think these are all very rare. That's happened in Africa, but in the current outbreak, there has been no reports of encephalitis, myocarditis, or hepatitis, right, so far. Okay, and even eye lesions have not been reported. These are all historical cases, mainly from Africa. So the cases that has been reported so far. So we just have to focus on this now, right? Let's focus on this. Catching those with a travel history. Let's catch all those who got a travel history and have a prodromal illness that is non-specific. So you should think of it, a prodromal illness, but has a travel history. For us, it has to click. And in such patients, we have to search high and low for skin lesions. And the skin lesions can be just a few. That's what we need to focus on, because all these severe manifestations have not been reported so far. Malaysia won't be that unlucky. I'm sure there will be cases in Europe. We'll have those severe cases first before we get our first case. And so let's focus on what we need to know now, which is travel history, prodrome, and the rash. Three things that we need to look out for. Guys, any other questions? There are a lot of repeated questions. Any other questions that you guys want to target in? Please go ahead.
Just to, sorry.
Lim, go ahead first.
Okay.
One by one.
Just to add on to what Dr. Suresh has said, another common features during prodrome will be the limb adenopathy, more than 70% reported. That's also the differentiating features to other rashes like chickenpox.
Rohani, you were saying something?
There's a question on, is it necessary to do chickenpox surveillance? As we know that chickenpox is disease of children. If let's say suddenly you see a lot of cases with among adult chickenpox cases among adults, and then you have to really ask the question whether, you know, look for limb adenopathy or those symptoms that mentioned by Dr. Suresh to really rule out for monkeypox, and especially for those clinics with which frequently visited by the special group, you know, so can really look for those cases. Thank you.
I think Dr. Patricia is trying to create an argument. Can you both of you answer? Which doctor should we refer for a patient with monkeypox? ID physician or dermatologist?
We can co-manage.
You just notify using your usual channel that you are comfortable with. Patricia, if you have a person, if you in your speed dial you have an ID physician, just call an ID physician. In your speed dial you have a dermatologist, you can call the dermatologist, no problem. No wrong door policy. You call us because we have not seen a case yet. We have not teased out all those details yet, and all of us will be willing to see these cases, right? So I think there's a question regarding the 10% mortality rate. Is it worrying despite all our reassurance that's mild disease? Kachan, you answer this?
Okay, the 10% mortality is mainly for the Congo Basin clade or the Central Africa, also known as the Central African clade. Somehow the one that is reported in the current outbreak, the initial data shows all are the West African clade, which is milder. That's number one. I shown the case fatality rates actually dropped significantly over the years from 1970s until now. Even there's no mortality reported in the large outbreak in the US. So it possibly relates to the level of medical healthcare facilities, level of care that you have as well. So all those complications, encephalitis, pneumonitis actually is quoted as less than 1%. The commonest complication actually is what Dr. Tang has highlighted, the superimposed bacterial skin infection, which is quoted about 20%, but that is actually treatable. So yeah, we must interpret the 10% mortality in the correct context.
Yeah, I think the other thing, but just to add, currently it is happening in healthy young adults, and so obviously it will be okay. But if we let it spread and it goes on to children, pregnant women, I think somebody asked about pregnant women, and immunocompromised hosts and older age group, I agree with you. We will have some, we will start sweating because we'll start getting severe cases, right? And so it is important that as it happens in young, healthy adults, we control the disease. With regards to HIV, there is no data yet as to whether there is any different manifestations in HIV, I presume. So can I think we'll have to stop. But before that, I would like to thank the three speakers, Dr. Rohani, Dr. Lim Kachwan, and Dr. Tang for this comprehensive lecture on monkeypox, and also would like to thank Malaysian Society of Infection Control and the Infectious Diseases EXCO for organizing this at such short notice and in a timely manner, and so that these information could be passed on to others. And a reminder, please let your colleagues know if you find it useful that this video is available in MyICID YouTube channel, and people can browse through this video to learn if they couldn't make it for this particular juncture.